Okay, here's our screencast on patient assessment. The full overview here is we're going to have an approach sequence, followed by an initial contact sequence, and then initial actions. Then a critical patient decision point. Is this a critical patient or not? And then do we need to do emergent transport or not? Then we're going to gather some info and gather some data pretty much at the same time. Decide on a plan and act on that plan, and then recheck, adapt, adjust, alter our plan as things go forward. One of the big ideas here is that we need to resuscitate initially and then continue resuscitation before we get into investigating exactly what's going on. Many of our patients will not have critical interventions right off the bat, but those that do need us to attend to those first before we try to find out exactly all the things that are going on. So resuscitate, then investigate. Here's the flow chart. It lays out the steps with some specifics, and we'll go through these one at a time. The approach sequence is something that is problematic sometimes to newer folks. And the question we need to ask is the scene safe enough to enter? The scene's never totally safe, but is it safe enough to enter? You need to use all available info, even if you have to pull information from dispatch, all available info, and make the best judgment you can at the time, given the facts and your experience. Ask questions. We should also consider the patient acuity versus our risk. If we're dealing with an alpha or bravo patient, and there's scene safety questions, then perhaps we're going to hold back more than we would on maybe a delta or echo, where the patient is predicted to be in extreme distress and need our emergent assistance, in which case it would be reasonable for us to incur a little bit more risk when there is something to be gained there. So your initial approach has a scene safety component to it, and then is there major bleeding and C-spine control? Is this a trauma patient where we're going to need to attend to bleeding urgently, hopefully assign that to someone along with C-spine control, and it may alter your position. You may decide to move to the head of the patient rather than be at the patient's side for these critical trauma patients. And then, of course, are there multiples, which would then alter our assignments of personnel and to some extent our priorities, but certainly the speed at which we're able to assess all these patients. So is it safe enough to enter? Is this a trauma where we need to deal with bleeding and C-spine? And are there more than one patient? The initial contact sequence is all about evaluating major body systems: neurological, circulatory, respiratory. So we're going to check their level of consciousness, which is different than their mental status. But basically, it's a level of consciousness check. Is the person alert or not? If they're not alert, then we need to consider airway control early on. And then we're going to evaluate circulation, ventilation, oxygenation. This is an estimating phase. We're only estimating in this phase. We're not going to take the time to measure actual values. So this whole initial contact sequence takes 15, 20, maybe 30 seconds. You're going to evaluate their radial pulse, their skin condition, by just estimating. Is the rate fast? Is the rate slow? Is the rate pretty normal? Same with ventilation. Measurement takes more time, and we'll do that after we've established this initial assessment of the major body systems. So again, are they alert? If not, you may want to position yourself to manage that airway. Is there a radial pulse? Is it there? Is it strong? How fast is it? And we're not counting here. We're just going, is it too slow, or is it too fast, or is it pretty much normal? And then on that radial pulse, if it's not there, you've got to add a carotid to it. And probably a good idea to consider would be just add the carotid if the patient's not alert. So radial if they're looking at you, radial and carotid if they're not. So circulation assessment, again, presence and strength of that radial pulse, a general rate estimate, and then look at their skin color, temp, and moisture. Move on quickly, probably while still holding that radial pulse. Move on quickly to ventilation, and you're estimating their breathing rate, too fast, too slow, okay for now. And then look at their effort. Are they using accessory muscles? Are they having a prolonged expiratory phase? And then what about depth? And then the last piece is oxygenation. Is there cyanosis? We're not necessarily measuring with a pulse ox right now because we're in the estimation phase. Now, if a second person is there where you can easily deploy a pulse ox, there's nothing wrong with that. Nothing wrong with adding the measurement in right now. It's just we can't slow down. We've got to move quickly. If your patient has a radial pulse, cool. If they do not, we're going to also need a carotid pulse. And again, we're measuring presence and strength as an estimate of blood pressure with the assumption that patients would normally have a radial pulse, and that would correspond to at least a not low blood pressure. It may be quite high, but it's at least not too low. And then the rate estimate on that pulse rate. Most of us can estimate 100 in our head based on our memory of how to do CPR compressions. And so a rate of less than 100 would be in the normal range. More than 100 would be considered probably in the abnormally high range. And then most of us can also estimate what 1 second is. And so if a pulse is slower than 60, if you don't feel a pulse beat any more often than once per second, then that would be considered to be pretty low. Rate estimate on ventilation, again, is it slow? Is it in the normal range? Is it too fast? And then are they working to exhale? Normally, patients would not have to expend any energy to exhale. It's just a relaxation phase. So if they're working to exhale, have a prolonged expiratory phase, meaning you probably inhale for a count of 1 or 2, and you exhale for a count of 1 or 2. If you're exhaling for a count of 3 or 4 or 5, then you have a prolonged expiratory phase. So the idea here is to look at effort. Actually cause yourself to consider their breathing effort. And then also accessory muscles fits into that just as a general picture. And depth, shallow, normal, or deep. So again, we're in an estimation phase. Then you take immediate actions, initial actions here. If there's no pulse, we need to put the AED on first. If there are 2 of us, one can be applying the AED while one starts compressions until the AED is ready to analyze. We need to control airway. Initially, that's going to be manually with a jaw thrust. We need to begin ventilations if needed. Seal any open chest wounds. Find all those wounds. Flip your patient. If you have 1 wound, let's look for more. And then to just show where the ALS actions would interface here, if this were an ALS provider with ALS capability, and in the initial actions then would involve pacer pads or defib pads so they can do transcutaneous pacing, synchronized cardioversion, or maybe a needle chest decompression at this point. So just putting the ALS pieces in here so everybody sees how it all fits together. So that now you're at this decision point. Do you have a critical patient? Have you found a life-threatening issue? And in some cases, that also means that immediate transport is indicated, particularly in trauma patients or patients with conditions that we can't fix. Not every patient that is critical is going to be determined to need emergent transport. A patient with a glucose of 30 with snoring respirations is critical, but that can be fixed on the scene and is best fixed on the scene. A cardiac arrest patient is critical, but unless it's a trauma cardiac arrest, emergent transport's not indicated, urgent treatment right there on the scene. So once you know you have a critical patient, you need to share that with everyone. It should not be a secret. And then direct those next critical actions. So we're pretty much focusing this presentation on what you would do as the team leader, as the patient contact person. So quickly, within 30 seconds, find a life-threatening issue, determine if emergent transport is indicated, and even though we can't transport, we should be preparing for emergent transport once transport capability is there. Communicate that and direct what we're going to do next. So the first time we're going to measure anything and gather any actual data is now. After we've gotten through this first 30 seconds or so of the initial sequence, then we're going to worry about gathering data. Again, the pulse ox, if you put that on a little bit earlier, no one's going to think that's bad. And pulse ox is a pretty leveraged activity. It gives you O2 saturation, so a measurement for oxygenation, plus it also gives you a heart rate count. We need to emphasize to remember to validate that heart rate count. If the heart rate count matches what your feeling at the pulse, right? If you feel a radial pulse and you watch blinky lights and the blinky lights are matching what you're feeling, then we can trust that heart rate and we can trust that pulse oximetry. If it can't even measure the heart rate because of low perfusion or whatever, then we certainly can't trust the O2 sat. Again, if ALS players are involved with ALS capability, this is where limb leads would go on. Blood pressure gets actually measured now. So as a standard sequence, we want to do things in this order. We want the pulse ox to go on first. And then if you have the ability to put limb leads on, we would do that. Obviously, in our first response situation, that's not the case. And then you would do blood pressure next. And then we need to emphasize that the pulse ox ought to be on one hand and the blood pressure getting measured on the other hand. Otherwise, you don't have valid pulse ox measurement. Now we're going to actually count the respirations. Before, we just had kind of a Goldilocks, too fast, too slow, just right. But now we're going to actually count it. And this is where you consider lung sounds at this point if it makes sense for that patient. Other things then happen. Glucose, temperature, pupil check, and then when there's ALS capability with ALS equipment, capnography and 12-lead fits in here as well. So whatever goes in down there in the glucose, temp, pupils, whatever, is going to be based on what that patient needs. We must consider checking these things in all patients, but very few patients will need all of these things checked. Going to gather some info as well, and we're going to do that while we're gathering data. And this is HPI, this is history and physical, history of the present illness sort of stuff. And this is a conversation. So what's going on? What happened? And then you kind of drill down on that. It should not be an interrogation going right down the memory aids of sample and OPQRST. This is also where the rapid trauma exam comes in. So a rapid trauma exam, head-to-toe exam, is to find all the life threats. You may have found one which allowed you to say critical patient, emergent transport, but we need to find all the life threats, and that's where this exam comes in. And then again, your conversation with HPI and what's going on in your pertinent history and meds. So sample and OPQRST were an acronym to help you remember that whole list. We never thought that these should be done in this order, but unfortunately it seems like that's happening. And so one of the first questions out of a crew's mouth to the patient is do you have any allergies, when it really doesn't make any difference most of the time, particularly to what we do in a first response role. So it's an acronym to help you remember the whole list, but have a conversation, ask what's pertinent, and do it with the purpose of trying to figure out what's going on. This is the investigation phase. Resuscitation continues. Now we add in some investigation. That's vitals, that's a head to toe, and that's some history. It's history and physical. So once you've got all this information, and this will take a varying amount of time, the initial contact sequence and urgent actions, 30 seconds or so to get to where you know what to do, and then you start taking those actions. Make your decision, is this critical patient or not? Do we need to prep for emergent transport? And then you start gathering some data and some info, and that'll take a varying amount of time depending on what's going on with the patient. But once you've gathered that, now you're going to think and make a plan. Match patterns to what you've heard about, what you've seen before. Pattern recognition is a good thing. The problem is pattern recognition also comes along with the risk of tunnel vision. Patients can have more than one problem, so just because you found one problem doesn't mean there aren't more problems. Just because you're told that it's a stroke doesn't mean that it really is a stroke, and even if you find stroke signs, there may be something else going on in addition. And then you're going to form kind of a field diagnosis list. Now, a lot of EMTs have been preached at that they do not diagnose. And so that's fine. No one's going to argue that too much, because really there isn't a great deal that can be done even if a fully formed diagnosis is made. Paramedics obviously need to have a field diagnosis. Since we're trying to present an assessment framework that works for all level of providers, this is where the field diagnosis list starts coming in for the medics, and there's nothing wrong with EMTs considering that diagnosis list as long as they stay focused on treating the things that they can treat rather than doing a complete investigation while no resuscitation continues. So once you've got your diagnosis list or diagnosis, make an action plan, and then persistently try to prove yourself wrong. Make sure you don't miss one. It's okay to jump to conclusion. It's okay to think you know what this is 2 seconds inside the door of the scene, but continue to try to prove yourself wrong and make sure that you've figured out everything that's going on. Then reassess, rethink whole things, adapt and adjust, and continue to take care of your patient. So initially get in within 30 seconds. Let's decide if this guy is really sick or not. Start doing some things to make that better. Make your critical decision, your critical patient decision, and then we gather info and gather data. And we can record that on a notes form, and we can provide that as part of a handoff. We should be prepared to give a handoff at any time in this process. It's unrealistic to think that we will get all the way to the end here. But that's the goal, is that we're going to get through this quickly, figure out what's going on, act in the ways that we can, and then give that handoff to the ambulance crew and let the care continue.